Hello again. So now your patient is inside the magnet. You move to the control room and you want to start scanning. First thing to do is you need to confirm your patient data. So confirm the name, date of birth, gender, make sure you have the right hospital number. Very important for MRI, cardiac MRI, to have the height and weight in the scanner. That's very important for the SAR management. SAR refers to the specific absorption rate. This is important to avoid overheating, which is a safety concern in MRI. And then check again your ECG signal. Make sure that you are happy with the signal and take a moment, look if your rhythm is regular or irregular. And this helps you to decide on the strategy to acquire your CINEs later. Now you start scanning, and at the beginning you acquire a number of fast acquisition. We do it with breath holding because we want to know where the heart is with breath holding. This is called Trophy. Trophy is a trade name for Siemens. It's a bit confusing in MRI is that every vendor has a trade name for sequences. I will be using Siemens trade name because that's what the scanner I'm used to. But Trophy is one of the gradient echo sequences. The first acquisition, as you can see, it's a number of 3 to 5 slices in each direction, in the sagittal, in the coronal, and in the transaxial. The importance of this is on the scanner you will have here marks that show you where is the isocenter of the scanner, so you can tell if the heart is in the isocenter or not. You will use this first acquisition to plan the rest of your scanning. It can help you, like if you have a device, if you have implantable loop recorder, you can see what artifact it generates and how you will go ahead with the rest of the scan. In this case, you can see that the heart is not actually in the center. This means that we need to adjust the isocenter. So you move the table and you scan again, and the heart now is in a better position. So now you are ready to start your actual scan. First thing is to decide on the area of interest, and the area of interest is the heart. So we go above the aortic arch, you go below the inferior wall of the heart, just below the diaphragm, and that's our region of interest. We usually start our anatomical localizers by the transaxial haste, again another Siemens name. So haste is one of the ultra-fast spin echo sequences, and you know a spin echo when you see the blood is black. The value of the anatomical localizers, it shows you the anatomy of the heart, the connection of the great vessels, and you can look at extracardiac anomalies. We acquire the haste free breathing, so we don't ask the patient to hold their breath, and we do it ECG gating, so we acquire in diastole. And the localizer will look like this. You have a number of slices. It can be 20, 24, 25. You go, as we mentioned, from the aortic, above the aortic arch, down to the below the inferior wall of the heart. You can acquire more localizers in other direction, in the sagittal or in the coronal. If we are to acquire in the sagittal, as you can see here, again a number of slices. And we choose the one slice from the transaxial where you have the biggest transverse diameter of the heart, and you go just outside the heart, covering anterior and posterior chest wall. You are not interested in the lung here or here. So our region of interest is the heart. If we are to acquire our slices in the coronal, again you decide on the region of interest, which is the heart again. So you go just anterior to the heart, make sure that the aorta is with you in the acquisition. We are not interested in this region, and you cover from one side of the chest to another. Again, we are not interested in the arms outside. We can acquire any localizers again in any direction, not as haste, but as Trophy again. So again as gradient echo, where the blood is bright, and this helps you to better localize blood vessels and see the connection, and sometimes it helps you to describe extracardiac abnormalities. So again, you acquire your localizers, the same number of slices you did before. Now you are ready to move on to acquire your first cine. So from your transaxial haste, you go to, or transaxial trophy, whatever you choose, you go to the one slice that you can see the LV apex and you can see your mitral annulus, and we are interested to go through the apex and through the mid of the mitral annulus. And now you acquired your first cine. The cine sequence is the SSFB, which is steady state free precision. We use this acquisition to plan the next slice. So this is the VLA. We call it VLA, which is vertical long axis. So now we cross-cut at the middle of the atrium, parallel to the AV groove or to the mitral valve, and you got this short axis where you can see your LVOT part of the aortic valve. To go to the next cine, we need another slice at the mid of the ventricle, which show us the left ventricle and the right ventricle, and I will explain in a minute why we do this. The reason why we acquire this slice is that next we want to move to acquire our true anatomical fourth chamber, and we need to use the three images that we acquired to create this. So you use your VLA to go through the apex and through the mid of the AV groove. You use the slice at the mid of the ventricle, you go through the lateral wall, septum, and importance through the RV apex. That's why we need this slice. You move up and down and make sure that the aorta and the LVOT are not part of your cut. And this gives you the true anatomical fourth chamber. The next slice is the LVOT, and to do this we use the slice we acquired from the first short axis where you can see the LVOT and you cross cut through it, and also you use your fourth chamber and you cross through the apex and through the mitral valve, and this gives you the LVOT. The LVOT crosscut is that you crosscut through your LVOT view. Now to start our short axis cine, so we will use the fourth chamber and we will use the VLA, the vertical long axis. Again, as we said, you start from the mid atrium, going all the way down, cover to the apex. You start from the mid atrium, going all the way down to the apex. You go perpendicular to the septum, you go parallel to the AV groove, and your slice thickness is usually 8 mm with a 2 mm gap, or you can do with 7 mm and 3 mm gap. And this gives you your short axis cine. Now to start acquiring your RV views, you go again to your localizers. You choose a slice where you can see the pulmonary artery, and you cross-cut the pulmonary artery and pulmonary valve, and this gives you your RVOT view. If you cross-cut through the RVOT view, you got your RVOT cross-cut. To get this view, which is the RV in and out view, you use those two views. You use your RVOT. This time you cross-cut going through the apex, and you use your anatomical fourth chamber and you cross-cut through the tricuspid valve going to the RV free wall. This gives you your RV in and out view. In this particular image, you can see some wrapping artifact here, but it is not affecting your cardiac structure. It's not affecting the RV, so you can still use this image. So this is the very basic cardiac MRI scan, or what we refer to as a volume study. So we have done just the basic acquisition to the ventricular volumes. We have not done any more sequences, STIR, GAD, mapping. All this hopefully will be covered later on in separate topics in other videos. Thank you for watching.